So we think, oh my goodness, something's got a risk to it. We have to weigh that against the benefits, don't we? You don't want to do something that's just got risks and no benefit. So what is the benefit to you? Well, there's a study called the National Polypectomy Study that's been going on since the early 70s. There's a 98% risk reduction for getting colon cancer by getting this screen. 98% decrease in your chances of developing colon cancer. It's one of the most effective screening tools that we have. Now, there's been some new studies lately. You may have read about the flat polyp. This is a polyp that occurs where the appendix is in the cecal area. They are more rare. You don't see them nearly as often. They're the same kind. They're hyperplastic or they're adenomatous. This flat polyp is simply this shape. It's not a different kind. They're hard to spot because they're flat. And the risk reductions, therefore, for them is about 70% because you miss a few. So, where to start? How often do you need to have this done? When to start? Where to start? 45 to 50 for most folks. If you have a family history, we want to tend toward the 45-year-old mark. Or sometimes if a family member, let's say they're 45 when they already developed colon cancer, well, then maybe you want to do it at age 35. We subtract 10 years. And it's either 10 years earlier or 45, whichever is younger. The stool occult blood thing, it's still kind of a controversy. Maybe start though at age 40 or 35. You have a family history, you're a little nervous. Again, once it turns bloody, then we really got a problem. So the jury's out on these right now. But until we get the genetic testing, I mean, we can't start doing colonoscopies on everybody if, at age 20, for heaven's sakes. I mean, that's overkill. So genetic screening tests might help sort out finding the people that are at risk at a younger age. Now, what's the schedule? I mentioned before, every 10 years, if there's no polyps, you don't have a family history, everything's fine, you only need this test every 10 years. If you find polyps, and I'm talking about the adenomatous polyps, every 5 years. Or, depending upon the size, the number of polyps you have, and what they look like, have they already started turning cancerous, for example, we may want to do it more often. I've got some people need to come back in a year, some people need to come back in 3 years, it depends. So where should you go to get a colonoscopy? What kind of facility are you looking for? Well, ask other people who've had colon exams. Find out where they went. Talk to them. How were they treated? Were they treated nicely? Did they feel comfortable? Check into the quality of the GI lab. What do I mean? The GI lab is what we call the area where we do the examinations. Well, how busy is it? You don't want one that does 10 a month. That's not enough experience. You would like to see a lab that does at least 3 to 5 a day. Up-to-date equipment. Do they have the new latest? Colonoscopes have changed a tremendous amount since I first started. They used to be fiber optic completely. Can you imagine a bundle of fiber of light-carrying glass? It had to be lined up perfectly so you get an image. And then you had 2 bundles with the light. Well, nowadays, the new ones are much smaller and narrower, and the way they've been able to do that is they have a little funny little photo chip at the end of them. That's what collects the image. And it's sent through a thin little wire instead of that big, thick bundle. Much more flexible, easier to clean, more comfortable, easier for me to use. So you want up-to-date equipment. And we talked about the cleaning and maintenance. Make sure that they have a program with which that they can tell you, yep, we cleaned it, we've got the cleaning equipment, we'd use the proper type of solutions. And then how close is it to the hospital? Now ours is the best because it's in the hospital. Most GI labs are either across the street or in the same building, maybe in a little bit different wing. But the point is, if you have one of those complications of perforation, for example, you don't want to have to drive 30 miles to get the treatment that you need. So you want to look for one that's pretty close to the hospital. So now, how do you pick your endoscopist? How do you know if I'm going to do a good job or a bad job, right? You look for evidence of certified training. You have to someone who's been actually trained. Yes, there are people who pick up a colonoscope and they just go at it. It's a little scary for the first couple hundred or so people. So the gastroenterologists, those are the GI guys, gastroenterology, gastrointestinal, what that stands for, they of course are the ones who started this. But frankly, there are not enough of them. Madison is short 3 or 4 gastroenterologists just in that city alone, let alone having people able to come out into the community. So residency training, and that would be mostly the general surgeons. Endoscopy is included in the residency training. It's not quite as focused as a GI fellowship would be, but they know how to do it very nicely. And then as postgraduate training, that's what I did. I spent 2.5 years specifically learning how to do this procedure. So you want to check that out. Okay. What about performance skills? Sometimes a little harder to find this out, but you certainly should ask questions. Do you find now, see that's 28% there. Now remember I told you 50% of people have polyps. This is specifically the precancerous ones. You know, so I did a look at all of my data, for example. I looked at everybody I did a screening colonoscopy on with no family history of colon cancer. And I found I was actually pretty darn close to that. My detection rate was 30%. I don't know if we have more polyps in this area or how why that is, but nationally it's about 28%. So a good endoscopist should be finding about 28% of people with the adenomatous polyps. I talked about reaching the cecum. That's important. If you don't reach the cecum, you haven't looked at the whole colon, so you want to make sure that at least 90–95%. If you're a GI fellow, that's 95%. The surgeons get about 90 to 92%. I looked at my data, and I'm actually at 99%. But I get a little obsessive. Anyway, okay, perforation rate. Well, 1 out of 400 is acceptable. You know, so that means, in my case, I get 1 or 2 a year, and I do about 800 procedures a year. So that's about where you should be. And then how long? Now, if you drop your friend off or your loved one and they're going to have a colonoscopy and you go to get a cup of coffee and they're already back in the room by the time you get back in 5 minutes, they've not had a good examination. The actual examination should be at least 15 to 20 minutes. And I take about, now very occasionally, I'm able to, I mean, I can't believe it, it feels like the colonoscope falls in. I mean, I'm at the end of it in like 3 minutes. That doesn't happen very often. It takes me about 5 to 10 minutes to get to the whole way, and then you should take about 5 or 10 minutes very carefully looking at the colon. There's a lot of nooks and crannies, there's a lot of folds. You really want to be looking at the entire surface to do a good job. And you should expect the patient to be in the room approximately 45 minutes, because we've got everything set up, we've got to do the sedation, we're going to do the exam, then we watch for a while, finish the paperwork, and then bring the person back. And then we keep you in the hospital about an hour, so you get your sea legs, so you can navigate out the hospital and have some kind of an idea to remember what you're doing. Now, how about communication skills? It doesn't do you any good to have the examination if you never find out the results. So, first off, do you understand the procedure? Has someone taken the time? Now, it can be the endoscopist or someone that he's instructed to help him or her. It can be the nurse, or it can be the endoscopy technician, it can be the scheduler who goes through, explains things one time. We like to explain it that way, then we get to the hospital, explain it again, and then I will answer any questions the patient may have left. So the person has an opportunity to hear the explanation 3 times. I think that's important. And will the endoscopist take the time to speak to your family members? You're not going to remember right afterwards. There are many people I've talked to, they look normal, they call me back later in the day, furious that I haven't said a word to them about it. So I personally like to have family members there so that I can talk to them. And I personally also send a personal letter to every one of my patients saying, this is what we found, this is what I would like you to do. Will your doctor get the report? I mentioned that I generate my report right away. It's put in the doctor's box. They have it whenever they go to their mailbox. It could be the same day or the next morning, so that your doctor remains in the loop. Now, what about a follow-up availability? The endoscopist has to be willing to meet with you later, maybe a week later, maybe 2 weeks later, talk about the polyps. Can you see them and talk about, well, what did you find? What did the biopsies show? What does it mean? Are you given enough time to ask those questions and get them answered? What about future examinations? Where do I go from here? Am I done? Do I have to have this again? Can I come back in 10 years? Or never? Or does it have to be in a year? How can you schedule this? How can you get it done? What do you need to do? Well, I would like you to talk to your doctor. If you have your own personal doctor, give them a call. Gee whiz, I'm thinking about this. I think I should have a colonoscopy. And then you can say, and you could then request, who would you like to have do it? Or if your own doctor's not in the area, or you don't have a doctor, you can call one of us who do this. There are 5 of us at this hospital who do this examination. Obviously me, and that's my telephone number. Actually, that's Robin's telephone number. And what you do is you ask for Robin O'Brien. As I was mentioning earlier before we started, I just think I'm in charge. There's a various number of women in my world that are in charge. The first one, of course, is my wife, Deb. Then there's a business manager, Tracy. Robin, she keeps me straight. What am I doing when? How am I doing it? And my nursing staff. You can't do this alone. You have to have a good team, and I appreciate my team. So I offer appointments for this examination 4 times a week. I do take Wednesdays occasionally as a day off, but I will do them on Wednesdays if it's an emergency. And I have a GI clinic on Thursday afternoons. That's where I was just before I came here. It's in the specialty clinic here at the hospital, and I have appointments for people who want to come and talk before an exam, after exam, or do I need an exam, or any other gastroenterologic complaint they may have. The surgical associates are also do this examination, and you'd reach them at their number there, at the 7900 number, and it's Bill Cotney, Mark Erickson, John McLaughlin, Christopher Nervy. Well, thank you all for coming.